we'll be discussing the high-risk postpartum patient and the patient who's going through grief and loss. We'll begin the discussion by discussing the high-risk postpartum patient. Here we'll consider bleeding or postpartum hemorrhage, infections including those of the reproductive tract, wound, and urinary tract, thromboembolic disease, and postpartum psychiatric disorders. We've talked quite a bit about vaginal bleeding associated with delivery. In the postpartum lecture, even the healthy postpartum patient has bleeding. But what is a postpartum hemorrhage? How do we quantify what a hemorrhage is? When does it become a hemorrhage? Well, this is a difficult predicament because the traditional definition was when there was a greater than 500 ml or 500 cc blood loss. Since then, however, when we've tried to measure and quantify with evidence-based practice, we've found that the actual amount of blood after a vaginal delivery that's lost is actually greater than 500 mLs on average. And for cesarean delivery, it exceeds 1,000. So we really need to take into consideration what is normal. Actual blood loss is really difficult to quantify. They've also found in these studies that small amounts of blood when they were lost were actually overestimated, and when there were large amounts of blood loss, they were underestimated. In addition, we have mixing of amniotic fluid in the operating room. They can be using gauzes and sponges to sponge some of that up, or they can be using sterile liquids during the process, so it can be difficult. In addition, symptoms often are not seen until women lose about 1,800 or 2,000 mLs of blood, because they have been kind of adjusting and preparing for a blood loss while they were pregnant. Symptoms would include decreased blood pressure because there's less blood circulating to put pressure on the vessels. As a compensatory mechanism, we might see an increased pulse rate. So the heart is beating faster so that the blood that remains in the circulation gets oxygen to the cells. She may become restless. She might have decreased level of consciousness and also decreased urine output because there's less blood going to the kidneys. But typically, women do not become symptomatic until they are very close to becoming hemodynamically unstable. Postpartum hemorrhage can be classified as either early or primary postpartum hemorrhage or late postpartum hemorrhage. In an early postpartum hemorrhage, the hemorrhage is occurring within 24 hours following delivery. This is often related to atony, or poor uterine tone. What would we call this when we assess it and it feels spongy, there's no tone? A boggy uterus. About 1 in every 20 mothers will experience some degree of atony. Also, the mother may have a laceration. This could be a laceration of the perineal area, toward the rectum, toward the labia, or up toward the urethra. It can also be a laceration of the cervix. So potentially, we could assess her, she's bleeding quite a bit, we massage her uterus, and it's firm. Maybe she has a cervical laceration, or a laceration somewhere else in her reproductive tract. She may be hemorrhaging from an episiotomy, where they surgically cut the area or the opening between the vagina and the rectum, some of that tissue, and that may be bleeding. There could be retained placental fragments. So the placenta typically separates, leaves the uterine wall, and she delivers it. However, if some of that placental tissue remains attached to the uterine wall, her body may still try to perfuse that. But is it going to recirculate back to her? No, she'll bleed it out. So this will result in a blood loss. She may have a hematoma. A hematoma would be a collection of blood. This could be somewhere in the vulvar area. She would be complaining of a lot of pressure. Often when you look at a patient, if you can see the hematoma, it appears black and blue, and it can look kind of like an egg. But she would be complaining of a lot of pressure with this. Maybe she had a uterine rupture. What's one of the risks for a uterine rupture? A VBAC, vaginal birth after cesarean. Although the risk is small, where the incision was from a prior C-section, that muscle isn't as strong in that area. So if she proceeds with a vaginal delivery with subsequent pregnancy, those contractions on that old scar tissue within the muscle, that's weaker, and the uterus can then rupture. Like I said, there's a very small chance of that, less than 1%. There can be problems with placental implantation, also, as we've discussed in the high-risk module. Coagulation disorders can also lead to postpartum hemorrhage. Since uterine atony can be a major cause of postpartum hemorrhage, we're going to explore this a little bit further. So what are some risk factors, or what can cause the uterus to not gain as much tone back after delivery, allowing for hemorrhage? Well, overdistension is one reason. Perhaps she had polyhydramnios, or a large infant, or this is a multiple gestation. So if the uterus is overdistended and the uterine muscle is overdistended, it might be more difficult for it to really clamp down for those smooth muscle fibers to contract. Also, a prolonged labor, dystocia, can make it difficult. Grand multiparity, what is this? We know that multiparous means having more than one pregnancy. What does grand multiparity mean? This means that she's had more than 5 pregnancies. This puts her at greater risk because the uterus loses its ability in tone. Also, medications can cause some of this. What medications do you think might prevent the smooth muscle from contracting? Well, we just talked about some medications that are used in preterm labor. Do you think perhaps if the patient had magnesium sulfate, they might be more at risk for uterine atony? Yes. So medications such as magnesium sulfate can prevent the smooth muscle from contracting, and therefore this might be related to postpartum hemorrhage through uterine atony. If they have a prolonged third stage, if you'll recall, what happens during third stage? Third stage is delivery of the placenta. So if it takes greater than 30 minutes to deliver the placenta, this could be associated also with atony and hemorrhage. So you'll see them using Pitocin also during this. Preeclampsia has been related to uterine atony. An operative delivery? What would constitute an operative delivery during a vaginal delivery? Think back. This would be the use of forceps or a vacuum commonly. And also the potential for retained placental fragments. Like I said, those can continue to bleed. How do we manage a postpartum hemorrhage patient? What kinds of orders do you think you'd expect? First of all, we'll massage her uterus to see if it's a boggy uterus, will this give it some tone? She may bleed while you're massaging it. You're not causing her to bleed, though. This is blood that's leaving the uterus that's already left her circulatory system. It's now sitting in her uterus, and her uterus is getting bigger and getting boggy. So as you massage it, that'll not only give it tone, but the blood or any clots that are in there may leave. So you may see you'd expect an order for IV access and some labs, such as hemoglobin and hematocrit, possibly a type of urine also if we're expecting transfusion. What will we infuse? If they believe that this is due to retained placental parts, they may take her for a D&C, dilation and curettage, to remove those placental parts and clean the lining of the uterus. If we're not having any luck controlling the bleeding, you may see them do embolization of some of the arteries. They may use uterine packing, so pack the uterus with a dressing that's coated in medication to help stop bleeding. They may have to ligate or cut and suture the uterine or iliac arteries feeding the uterus. In cases where we cannot stop bleeding, even though we've attempted all of this, you may see the discussion heading toward that of a hysterectomy or removal of the uterus. With this, we are taking away her ability to have additional children. However, if we can't stop bleeding, as I said, you may see the discussion in the plan of care turning toward this, but this would be a last resort method. Lacerations can be another source of early postpartum hemorrhage. These can be laceration or tears in the perineum, vagina, or even of the cervix, and they're associated with bright red bleeding, and you assess her uterus, and her uterus is firm. So it's not coming from the uterus, there's a laceration somewhere else here. Risks for a laceration include nulliparity, so this would be her first delivery, so she's at greater risk for a laceration, having an epidural, a precipitous delivery. What kind of time frame is associated with the precipitous delivery? Do you remember? It's 3 hours or less. Macrosomia, which is a large baby, an operative delivery. Again, that would be the use of forceps or vacuum-assisted vaginal delivery, and also if the patient has had Pitocin during her delivery. These are all risks that can be associated with a laceration. Again, we would assess the patient and see bright red bleeding and a firm fundus. Retained placental fragments, so where there's a partial separation of the placenta, so some of the fragments of the placenta remain in the uterus, as I discussed a little earlier, related to atony. So this could cause the uterus to lack tone in and of itself, or it can cause a late postpartum hemorrhage. This can also be associated with the provider massaging the fundus prior to separation of the placenta. So this practice is generally avoided by the delivering provider. After delivery of the placenta should be inspected to make sure that it is intact. They may do a uterine exploration, which is just that, looking to make sure that the uterus is clean, that all of the placenta has been expelled. If there are retained placental fragments, there might be a possibility for a dilation and curettage to remove that. However, there's some school of thought that this may cause increased bleeding. A postpartum hemorrhage may also result from a hematoma. A hematoma, as you probably know, is a collection of blood due to injury of a blood vessel. In this case, it results from birth trauma or bleeding of a repair site, and then that allows for the collection of blood under the skin. You can see under the picture, this is a right vulvar, or almost affecting the labia, hematoma here in this picture. Risks for formation of a hematoma include preeclampsia, first full-term delivery vaginally, a precipitous labor that doesn't give enough time for all the tissue to expand, an operative delivery of forceps or vacuum extraction, and vulvar varicosities. These are when a woman has varicose veins in the vulvar area. Management depends on size. If they're small, less than 3 centimeters, they're often managed with ice packs and analgesia. After 24 hours, we can use heat on them, and they're often allowed to kind of reabsorb. If they're larger than that, they may consider an I&D. This stands for incision and drainage, so they would evacuate the clot. Also, the hematoma, the blood sitting there pooling and reabsorbing, is a great source for infection. So you will also see the use of broad-spectrum antibiotics used prophylactically to prevent infection or prevent an abscess from forming. Uterine rupture can also be a cause for major postpartum hemorrhage. Risks include prior surgery or C-section because the scar there makes the muscle thinner, so more likely to rupture, although again this is very rare. Fetal malpresentation, where the baby is not occiput anterior in a vertex cephalic position. Grand multiparity, again, what does this term mean? Where she's had more than 5 deliveries. An operative vaginal delivery with forceps or vacuum extraction, and a Pitocin induction. Any of these would put her at greater risk for uterine rupture. So what would the patient report? They report intense pain. Intense, severe abdominal pain. And they may have minimal bleeding or they may have diffuse bleeding. It just depends on if the blood is kind of sitting in the abdominal cavity or if it's coming out vaginally. Management for this would most certainly include surgery, fluids, and blood replacement. Late or secondary postpartum hemorrhage occurs between 24 hours and 6 weeks postpartum. This is less common than a primary postpartum hemorrhage, where a woman bleeds within the first 24 hours of having a baby. This is less common, however, very stressful to women because often they're at home when they have a late postpartum hemorrhage. This is often related to retained placenta or subinvolution. Involution refers to the process of the uterus going back to the pre-pregnancy state. So subinvolution implies that it's not returning to its pre-pregnancy state. And this is often related to the site where the placenta was and its healing or lack of healing. So oftentimes a patient will come in for her OB visit or will call and say, something's wrong, I'm still bleeding. What would this type of OB assessment likely reveal if there's subinvolution? Well, typically the fundal height is greater than expected. So her fundus wouldn't be going through the involution process. -1, -2, -3, -4. It wouldn't be going through that. So it would be higher than expected. And also, her rubra might persist with lochia rubra. It may not go to serosa and then alba as we would expect it to. So she may have rubra that's persisting for longer than 2 weeks. And this would be suggestive of subinvolution. So she may report scant brown lochia or very heavy bleeding. She may have a backache. These would be signs that she would need to call her provider, and we would be suspecting subinvolution, late postpartum hemorrhage. How do we expect a postpartum patient would be managed if she's having a late postpartum hemorrhage due to subinvolution? The use of methergin might be prescribed. This would help contract her uterus and also vasoconstrict. If they believe that infection is present, they may order antibiotics. And if they believe that it's due to retained placenta, they may do a DNC, dilation and curettage, to help clean up the lining of the uterus. A puerperal infection refers to a postpartum infection, or infection of the reproductive tract occurring within 6 weeks following delivery. This can be a vaginal delivery or a cesarean section. Puerperal morbidity, JACO refers to as having a temperature of 38 degrees Celsius or higher for any 2 days of the first 10 days postpartum, exclusive of the first 24 hours. So we don't count the first day. We allow them to have a temp the first day, but days 2 through 10, if they have a fever for any 2 of those days, this is a consideration. Who do you think is at greater risk? I mentioned that this can happen with a patient who's had a vaginal delivery or a cesarean section, but who's at greater risk? Certainly a cesarean section patient is at greater risk for infection because they have the open abdominal incision. Why is it that some patients may get a reproductive tract infection? Well, following rupture of membranes, bacteria from the vagina can easily access the uterus. Typically, the uterus is sterile. However, when the rupture of membranes takes place, it allows bacteria, even that were in the vagina, to go up through the cervix, because the cervix is open, and enter the vagina. In addition, we have the placental site which let go, and that can be a great medium for infection and bacteria. Risk factors include having a cesarean section delivery. They're about 10 times more likely to have infection of the reproductive tract. Diabetes, these patients, if they have vascular involvement, certainly can heal less well and can have more infection, about 4 times more likely if they have diabetes. If they had PPROM, what does this stand for? Do you remember? Prolonged premature rupture of membranes. So if their membranes were ruptured for a long period of time, perhaps they could have chorioamnionitis too, and this could be related to PPROM, infection of the amnion in the sac in the pregnancy. If they've had multiple vaginal exams or lapses in our aseptic technique, So certainly these are nosocomial infections, infections that they received that they didn't have prior to coming to the hospital but received once they were there. If they have a compromised health status, they're also at greater risk. Their body isn't as able to fight infection. Any internal monitoring, such as a scalp electrode placed on the baby's head or an intrauterine pressure catheter. The more we're monitoring a patient internally or doing exams, the more chances for bacterial contamination. Also trauma, such as lacerations, episiotomies, use of forceps or vacuum extractors. And retained placenta or manual removal of a placenta also place the patient at greater risk. What is the most common type of postpartum infection? It's endometritis, which is an inflammation of the endometrial lining of the uterus. This is the lining typically that a woman would shed with her periods. In this case, the lining, the endometrial lining becomes inflamed and infected. Signs and symptoms of endometritis include bloody vaginal discharge, foul-smelling vaginal discharge, uterine tenderness. She might say that her abdomen and her uterus are very tender, or when you go to palpate them, they're tender. Fever and tachycardia, which we would expect to see with infection. Causative agents include group beta strep, chlamydia. They can also be caused from other bacteria, such as E. coli. Management then would include antibiotics. We typically use broad-spectrum antibiotics. When a woman presents with these symptoms, they generally assume that the woman has endometritis. Peritonitis is when a reproductive tract infection spreads throughout the entire peritoneal cavity. This can be where it gets in the lymph system or the blood and spreads. Peritonitis is very serious and can be life-threatening. Postpartum patients, both cesarean section and vaginal delivery patients, are at risk for wound infections. Cesarean section incisions, as you can see, are at risk for infection. We would assess them for redness, foul drainage, warmth, and how well approximated they are. It's important, if you notice that it's red or warm, to outline the area so that you know if that is growing or getting bigger, or you know if it's changing from the prior shift. The bottom picture shows, in some of these cases where there's infection, they may actually open up the incision if there is drainage in there to let some of that out. And then we would do wet to dry dressings and allow that area to heal. The bottom picture is a picture of one of those kind of incisions. Certainly, though, looking at these, you know that something is not right when you would do the Rita assessment, assessing again for redness, edema, ecchymosis, foul drainage, and how well approximated the area is. With a vaginal delivery patient, they are also at risk for wound infections. These are often related to a laceration or episiotomy. Postpartum patients are at great risk for urinary tract infections. Well, why? Certainly, we've talked about the postpartum diuresis, where they will be urinating frequently. Well, along with the need to urinate frequently, they have increased bladder capacity and decreased bladder sensitivity. So if they have decreased sensitivity and their bladder is holding more and they're diuresing more, they're at great risk for urinary tract infection because they have more urine and less ability to feel the sensation and need to empty it. In addition, they may have some perineal edema, as we've discussed, making it difficult to void. They're also at greater risk because we have allowed the introduction of bacteria through catheterization. If they were a C-section, they had a Foley catheter inserted, or if they had an epidural, they were catheterized every 2 hours to empty the bladder. And the method of delivery is such with female anatomy, the introduction of E. coli is right there, so this can be a great source also of infection. So, overdistension of the bladder is the inability to empty the bladder completely because of trauma. What kinds of trauma did we have? Well, it can be from the birth itself. So a woman who's never had a baby, and this is her first baby, would be at greater risk for this. If she's had the use of forceps or vacuum, if she's had the trauma of a laceration or an episiotomy. How can we help the patient manage this? We may have an order to straight cath the patient, and hopefully then she would have the ability to empty, and we would encourage the patient to empty her bladder completely. Sometimes it's helpful to let a patient sit in the bathroom for a while. Sometimes I'll try the tricks that my mom used to try when I was little, turning on the faucet, that kind of thing, to encourage her to go. But we don't want her to get into a situation where she's over-distended, the urine backs up, or has the ability to harbor bacteria, giving her an infection. So we have some issues in the urinary tract, as we've discussed. They are the retention of urine for a multitude of reasons, the decreased sensitivity, the diuresis. They are bacteria that she's been exposed to through the delivery process and through multiple catheterizations potentially, and trauma from the delivery process itself. So she's a setup for urinary tract infection. Cystitis is a lower urinary tract infection. This affects the bladder. Pyelonephritis is an upper urinary tract infection affecting the kidneys. Sometimes patients with kidney infections will present with flank pain. How would a patient with a bladder infection present potentially? These patients might have urgency, frequency, burning upon urination. It can be difficult to assess bleeding with urination because they do have the lochia in the hospital. How do we manage a patient with the urinary tract infection or suspected urinary tract infection if they're complaining of some of those symptoms? They would most likely order a urine culture and sensitivity. Antibiotics would probably be ordered, and pyridium. What's pyridium? Pyridium acts to prevent spasms and kind of often gives a numbing or analgesic property too. Mastitis is an inflammation of the lobular connective tissue of the breast. This is generally unilateral, and it's more frequent among nursing mothers, generally between 2 and 8 weeks into breastfeeding. However, it should be noted that even non-nursing mothers can get mastitis as their milk comes in and it becomes infected. If left untreated, mastitis can progress to an abscess. What would a woman with mastitis complain of, or what would we see? Typically red, painful, swollen breasts. Like I said, this is often unilateral, so just on one side. What causes mastitis? Certainly milk stasis can cause mastitis. If the baby isn't positioned to allow for emptying of the breast, or if there's failure to alternate breasts, if the baby is having difficulty nursing, or the mother and baby are separated, or she abruptly stops nursing. These would all be reasons where there could be milk stasis. Also, if her milk has come in and she's not nursing, the milk is sitting there, it is a great medium for infection. Bacterial invasion is another reason why mastitis may occur. This could come from poor hygiene, not washing hands, using plastic-lined breast pads to trap moisture and leaving that against the nipple. Also, trauma can cause infection. If there's a poor latch, like we've talked about, if the mother's nipples get kind of cracked, blistered, bruised, if there's a poor latch, certainly that can lead to skin breakdown and invasion of bacteria there. So we do want to make sure that the baby is latching properly and that we're assessing the nipples for any cracks. If there's obstruction of the ducts, this could be from restrictive clothing or constricting bra or an underwire bra where the duct is constricted or obstructed. Failure to empty the breast, like we've said. If the mom has attempted to abruptly wean, if she's missed feedings, if the baby is sleeping for prolonged periods of time, like sleeping through the night, or has a favorite side. Sometimes babies will only nurse from one side, and we're not sure exactly why that is, so we can try on the breast that's favored less to try different positions to help the baby nurse from both sides. And of course, if the mom is fatigued or stressed or has a poor diet, this can put her at lower resistance also. So how do we treat mastitis? As you can see in these pictures, it looks pretty painful. Typically, she'll say, my breasts are killing me, and you'll look and you really see that they're often red, shiny, hard. Well, we would encourage her to breastfeed frequently to prevent milk stasis, to make sure that the baby has a good latch, to make sure that she's emptying completely, and tell her to wear a supportive bra, not one that constricts, of course, but one that's supportive if she does have mastitis. We can also encourage her to use ice packs for comfort and to kind of decrease some of the inflammation, and then we would expect the provider to order antibiotics and potentially analgesics for the pain. Postpartum patients are at risk for thromboembolic disease. A venous thrombosis is simply the formation of a blood clot. Thrombophlebitis is when there's inflammation in a vessel, and this leads to the formation of a clot. Causes include hypercoagulability, venous stasis, and blood vessel injury. Well, think about pregnancy and look at these causes. And why do you think a postpartum patient is at greater risk for clot formation? Certainly, pregnancy is a time of hypercoagulability. And in addition, there's compression of the common iliac vein as the large uterus gets larger, and this leads to venous stasis. So these factors make the woman who has just delivered a baby at greater risk for clot formation. We're not done yet. There are still more factors that add to the possibility of a woman forming a clot in the postpartum period. These include increased clotting factors, postpartum thrombocytosis. What's thrombocytosis? This is where there's an increase in platelets, and the platelets are more sticky. There's a release of thromboplastin from the placental site and fetal membranes, and also increased fibrinolysis inhibitors. So why is all this happening? Well, actually, this is a protective mechanism to prevent the woman from bleeding or exsanguinating after having a baby. However, it also places her at greater risk for clot formation. Those at higher risk for clot formation after delivery are those who have had a C-section, women who've been immobile. Why might a woman be immobile? Well, potentially she was high risk during her pregnancy and she was placed on bed rest. So that would put her at greater risk for clot formation. Smokers are always higher in incidence for clot formation. Having a prior clot places her at higher risk. If she has varicose veins or diabetes mellitus, if she's of advanced maternal age or multiparity, she's had greater than one child. If she has anemia or inherited disorders, all of these place her at greater risk. Superficial thrombophlebitis is when a clot forms in a superficial vessel. So this is something that happens more often in people who have varicosities. Symptoms might include tenderness because it is superficial. You can see localized warmth and redness, like in the picture. The patient may have a normal temperature or they may have a slight low-grade fever with some tachycardia. In addition, they may tell you that they can feel a bump, or what we're doing is palpating a cord. You can kind of feel where the vessel is inflamed and where the clot is. Certainly we wouldn't want to massage that, but you may note that in your assessment. Management would include heat to the area, elevating that extremity, the use of analgesics for pain control, and bed rest. You would also see elastic hose. Signs and symptoms of a deep vein thrombosis include edema, tenderness, pale limb color. You may hear people call this milk leg. Why would it cause the limb to be pale and edematous? Well, the clot, or the thrombus, can prevent blood flow to that area, or to the greater extent of the leg. So it can cause it to be pale in color and then edematous too. The patient often has a low-grade fever followed by a spike in their temperature, and with fever may have chills. Management includes the same things in the superficial thrombophlebitis, but this, with the deep vein thrombosis, often requires heparin therapy or some kind of anticoagulant therapy ordered by the physician. Moving along to postpartum psychiatric disorders, we can consider postpartum major mood disorder. This is commonly called postpartum depression. Note that this is different from kind of the baby blues or postpartum blues that we talked about within the normal healthy pregnancy that can last kind of up to 2 weeks. With postpartum depression, typically when you look at studies, about 50% of these patients have this for at least 6 months. Symptoms would include sadness and crying, sleep pattern disturbances where maybe they want to sleep all the time or they can't sleep well at all, changes in appetite where they're either gaining a lot of weight or losing weight, they don't have an appetite, difficulty concentrating and making decisions. These patients will often make statements that tell you that they have feelings of worthlessness or they're inadequate, maybe as a spouse or as a new mother. They lack interest in things that they would normally find pleasurable. Maybe they really like, doing things with their kids or going on walks, and the things that they used to like, they're just not interested in during this period of time. And they also commonly lack an interest in their appearance, so you may see them having difficulty providing their own activities of daily living. Showering every day, doing laundry and wearing clean clothes, keeping their hair well kept. And maybe in the past these women were really put together. So this would be postpartum major mood disorder, commonly known as postpartum depression. Risk factors for postpartum major mood disorder include having a first baby, ambivalence about the pregnancy. If they had a lot of ambivalence, we discussed ambivalence being somewhat normal, but if that ambivalence kind of carried forward. If they had the postpartum blues, kind of that bluey period for the first, 2 weeks or so, they're at greater risk for this lasting and becoming postpartum major mood disorder. If they have a prior history of postpartum depression with a prior pregnancy and delivery. Lack of social support and lack of family relationships can place patients at risk for postpartum depression as well. If they had complications during their labor and delivery or postpartum experience or during their pregnancy, this can be a setup also for the major mood disorder. Loss of a newborn. Certainly grief is something that can put patients into depression many times. And if they're in a situation that contains domestic violence. How do we expect postpartum major mood disorder to be managed? Well, what is the priority? Let's talk about that first. The number one priority is patient and infant safety. Certainly if you feel that she is at risk to herself or at risk to hurting the baby or she states one of these things, that is our number one priority with these patients. Also, we would expect some antidepressant therapy as far as medications are concerned, and psychotherapy. And these also would depend on what her risk factors are that we just discussed. Were any of those there? Does she lack social support, or is she in a domestic violence kind of situation? Was this a fetal loss? Were there complications? Those kind of things might benefit from some psychotherapy. Also, it's really important that we educate patients about postpartum depression prior to discharge so they know that the blues and then, if that leads to postpartum depression, longer lasting and more severe, that they should contact their provider in looking to see that they do have a good social network in place. Postpartum psychosis is very rare. However, when it happens, there's generally a lot of media attention surrounding it. Symptoms of postpartum psychosis include irrational thinking, confusion, delusions, hallucinations. Many of these things are often surrounding the infant. They're often agitated, hyperactive, and also have insomnia. Risk factors for postpartum psychosis include prior postpartum psychosis, history of bipolar disorder, obsessive personality, social factors such as lack of social support, lack of family involvement, and poor socioeconomic status. Management is primarily centered around safety being the first priority. Certainly we would not want this woman to harm herself or harm her baby. Like I said, some of the hallucinations and delusions often surround the infant, so we want to make sure that the baby will not be harmed. The patient is often hospitalized and medications are ordered. Psychotherapy and cognitive behavioral therapy are also a priority during this. And then she may need assistance with the newborn while she is hospitalized and afterward, just to make sure that everybody is safe, that she's meeting the care needs of the baby and herself. Grief and loss is a subject that some people don't consider when they think about OB nursing. However, our patients do experience grief and loss throughout pregnancy or after delivery. It's an expectation of most providers, if you wish to work in OB, to care for these patients and to do so with grace and dignity. A lot of people don't really think about grief and loss and how it pertains to OB. When they think of OB, we often think of, pink headbands and bows and blue bubbles and little stuffed animals kinds of things. However, there are these patients, and it's important that we care for them in a very kind and warm-hearted way and define the loss as the patient defines it and see what it means to them. This is a subject that can be kind of taboo for some people, but nevertheless it does exist, and we'll be exploring common causes of perinatal loss, maternal physiological implications, post-birth evaluation, and the experiences of loss and how we can best care for patients undergoing loss. Perinatal loss is defined as death of a fetus or infant from conception through 28 days following birth, so it's important to consider some terms here. Essentially, this can include a miscarriage or early loss of a pregnancy all the way through a newborn who is essentially 4 weeks old. So intrauterine fetal death, IUFD, you often hear this in the clinical setting, includes fetal death that occurs while in utero, so prior to being born. A stillbirth or fetal demise is when this occurs after 20 weeks gestation. A stillbirth or fetal demise, again, dies in utero, so it's not born with the heart rate or attempting to breathe. A neonatal death, however, is when a baby is born well or not well. However, it's breathing, has a heart rate, it is born alive, that is, and then dies prior to 28 days of life. Common causes for fetal death, this would be intrauterine fetal death, occurring after 20 weeks gestation, are often unknown. Some of the causes that we do know about can be related to asphyxia or lack of oxygen, congenital anomalies, placental problems like placental abruption, which is where the placenta lets go so then the mother can hemorrhage and also the fetus isn't getting oxygen during that time, placenta previa, cord accidents. So this could include a cord prolapse. If you remember, that's where the water breaks and the cord comes out prior to delivery, and this prevents oxygen flow and blood flow through the umbilical cord, or a cord around the neck. Growth restriction can be a cause of fetal death. Alloimmunization, where a mother is Rh negative, the fetus is Rh positive. She has antibodies against Rh positive blood, and then those antibodies attack this pregnancy. This can be a cause for fetal death. Preeclampsia, diabetes, lupus, thyroid disorder, and kidney problems can also be causes for fetal death. But as I said, sometimes we just don't know what causes the loss. So the cause of fetal death is often unknown. However, there are some risk factors that we know place a woman at higher risk for having a loss. These include first baby, multiple gestation. Twin pregnancies are approximately 2 to 3 times more likely to be at loss, and triplet pregnancies are about 4.5 times more likely than a singleton pregnancy would be. Obesity, often because of its relationship potentially to diabetes, presence of an infection, or maternal clotting disorder. So we do know that these are risk factors that would have a woman at higher risk for experiencing fetal loss during pregnancy. There are several maternal physiological implications of a fetal demise, particularly when the demised fetus remains in the mother's uterus for a period of time. Perhaps she didn't know that the baby has demised. One of these risks, obviously, is infection. Another is DIC, disseminated intravascular coagulation. What happens here is thromboplastin is released from the fetal tissues that are now decaying, and this activates the maternal clotting system. So here's what's happening. If you listen to the name of the problem here, disseminated intravascular coagulation. So within her vasculature, her blood is beginning to clot. So if she is using up her clotting factors, this can put her at risk for what? This puts her at risk then for bleeding very, very heavily. Treatment of DIC often includes massive amounts of blood transfusion, blood products, because again, her blood products are binding to themselves, and this is initiated through the release of thromboplastin that was released from the decaying fetal tissues. Post-mortem studies often give us some rationale or reason for demise. If this is important to the parents and the provider, this would be offered. However, this is the parent's choice to do this. A couple of mechanisms here for post-mortem studies include autopsy. Again, some parents may want to go forward with this so that they can have a causative factor in the demise. Others may opt not to have an autopsy done. Chromosomal studies, particularly important if the provider feels that there was a genetic issue here that may have given rise to the demise. A real concerning issue if these parents want to have additional children. Cultures would be done if they feel that infection may be a source. A visual examination can be done. This can be done in many, many circumstances and can be very, very helpful, particularly in those cases where parents don't want something like an autopsy to be done. So by visual examination, what are we going to look at? We can look at the placenta. Is it intact? Was there an abruption? We can look at the cord. Was there a knot in the cord? Were there 3 vessels in the cord? What does the intactness of the cord look like? We can also inspect the fetus or the baby. Does it appear that there's an obvious congenital malformation? So a visual examination is very helpful and is not all that invasive. In addition, blood tests can be done. What could we look for in a blood test? We could look for a glucose level. Maybe diabetes was a factor here. Potential alloimmunization might be an issue. And also, x-rays or MRIs can be done. Again, another option that's not quite as invasive is the autopsy for parents who opt not to have an autopsy but still do want some reflection of what happened here. So these are some of the post-mortem studies that can be done. Again, we involve the parents in this, and it's ultimately the parents' decision. As we work with patients who have experienced a loss, it's important that we understand some terms. Bereavement means to suffer a loss, or to have something taken away, or to be deprived of something. This is bereavement. Grief is the reaction to that loss. Grief might include physical symptoms, thoughts or feelings, functional limitations, or spiritual responses. And the process of mourning is the process of incorporating the loss into one's life. So this might be weeping, or visiting a grave site, or doing certain things on the birthday or anniversary of that individual. And mourning can be influenced by several factors. These could be personality types, gender, family dynamics, religious or cultural norms. So the experience of loss is one that is very individual. And when we talk about perinatal loss, people really do experience this differently. Some people you might see in the OB triage area come in and feel that they've suffered loss with a very, very early miscarriage. Others may discount that and feel that it's not a loss and be able to move on very quickly. We define the loss as caretakers by assessing where the patient is, how they define this within their lives, and supporting them through that. Common reactions to loss. Well, everybody grieves differently. Certainly, some people are more stoic. Others are more likely to cry easily. However, there are some common reactions. Shock or numbness, confusion, denial, these can be very normal. Maybe a provider tells parents that there's no longer a fetal heart rate, and they say, well, this just can't be. I felt the baby move. Or yesterday at the doctor, everything was okay. Can I get a second opinion? denying what they're saying is true, wanting a second opinion. And certainly we would give a second opinion with something like that. Some people initially have a lot of anger or protest what you're saying, perhaps anger with the provider, or guilt. Maybe I shouldn't have been on that snowmobile when I was 6 months pregnant. Or this is my fault, I didn't take my prenatal vitamin last week. Certainly we want to reassure these patients that nothing they did made this happen. Some people feel a lot of loneliness. And you may see patients who are going through shock or denial or numbness once they've delivered, once they're holding that deceased newborn, that they may transition into feelings of anger, guilt, loneliness. So there's not just one right way to behave or one way that we'll always see. What are some factors that affect the way somebody responds to the loss? Certainly age has something to do with it. Gender has something to do with it. Family dynamics and support have something to do with it. Spirituality and religion, the way they define this, has something to do with it. In cases of pregnancy, depending on where the loss is, when do they believe life begins? Or was this related to an infertility pregnancy? All of these can really play factors in the response to the loss. So we will again want to see what this loss means to this family and care for them through this journey based on how they define the loss and what their reactions to the loss are. We'll consider several frameworks of understanding perinatal loss. One of them is the dual process model, which considers loss and restoration. So there are two things going on here, two processes going on simultaneously. One is addressing the actual loss. The other is regaining balance in light of loss. So one of the processes going on here is addressing the loss, confronting the loss. The other process that's going on simultaneously then is regaining balance. How do I move on from here, given the fact that I have experienced this loss? Attachment theory contends that we have bonds or attachment to people who are significant in our lives. The intensity of grief then can be assessed by considering attachment to the anticipated baby in the case of fetal loss. There are 9 things to consider when considering attachment to a pregnancy and baby. 1 is planning the pregnancy. 2 is then confirming pregnancy. 3 is accepting the pregnancy, kind of getting over the ambivalence and accepting the pregnancy. 4 is starting to feel fetal movement. Do you remember when this typically happens? This typically happens around 20 weeks gestation. The 5th is accepting the fetus as an individual. Number 6 would be the process of giving birth. 7 is when they see the baby. 8 is touching the baby. And 9 is giving care to the baby. So in the case of fetal loss, when they don't have the opportunity to do some of the higher level attachment kinds of things, what can we ask to determine where they are in this? We can ask things like, have you named the baby? Do you have a nursery that's ready? What are your future plans for this baby? See what kinds of personal stories they have about their pregnancy. So this is the attachment theory. We're trying to link here grief with attachment to the pregnancy and plans for this newborn. Under the attachment theory, it's important for these parents to have a way to maintain a bond with the deceased infant. The meaning reconstruction theory contends that people redefine themselves after experiencing a loss through searching for a meaning within all of this. Common questions within this model would be something like, why did this happen to me? Or, am I still a parent? So they're searching for meaning within the loss and seeking to redefine themselves and redefine life after the loss. Studies show that people who find positive meaning within the loss cope better long-term than those who do not. This is the meaning reconstruction theory, redefining life after loss through searching for meaning within it. The caring theory is a theory about how we should care for the grieving family. Again, all of these situations are different and are very individual. But as a rule, there are 5 parts to the caring theory. Knowing pertains to understanding the loss as it pertains to the parents. So, again, knowing what this means to these parents. Being with is the ability to give of yourself to the family. So this extends beyond just being professional, but actually, giving heartfelt care. I think it's okay if you're presenting a baby, a deceased baby, to the parents for your eyes to well up with tears. I mean, not that you want to be melting down and that sort of thing with the family, but I think it's okay to show that you're a human being and you're more than, just a nurse, that you're a human being. You're being with them through this experience. Doing for is the 3rd aspect of the caring theory. This is doing for the family as you would want others to do for you, kind of the golden rule from when you were a kid. You would do for them in this situation of loss as you would want others to do for you if you were going through this. Enabling is the 4th aspect of the caring theory. This is enabling parents to get through this journey that can be very unfamiliar to them and helping them with this. An example that I have of enabling is when I was caring for a patient who had gone through a loss. She wanted me to call friends and family members and help her plan the funeral, which I did, and then call friends and family members and, help them through this. Help them with what to expect when they got to the funeral home. So this is helping them through this uncharted course that can be very unfamiliar to them. Maintaining belief is the 5th aspect of the caring theory, and this is continuing to believe that the parents can get through this loss. This is the caring theory. We also use the word responding as an acronym. Again, we love acronyms in nursing. Responding, if you take each letter, can give us a good acronym for how to respond to a patient and family who are grieving after a loss. R, recognition and validation of loss. It's important for us to be able to recognize what they're going through and validate that this is a loss. We don't want to kind of sweep it under the rug and pretend like nothing happened. That's what makes perinatal loss something that's unique, is that people don't really know what to say. Is this a real loss? It's not really somebody who they knew, so some people brush it under the rug. Other people really feel that this is a taboo, and they don't know what to say or how to respond. So recognizing that this is a valid loss if the patient defines it that way. E is being emotionally available to the patient. We don't want to be cold or calloused, but be emotionally available to your patients. S is spiritual and cultural accommodations. Certainly if they would like us to do a blessing and that's something that you're comfortable with, or if they would like us to call the chaplain or somebody from their church or from their culture, if they have any kinds of rituals they'd like to go through, certainly we would do everything we could to help accommodate that. Being physically present, just sitting with them, even if there are no words, just to be there. You don't have to say anything. It can just be a hug. It can be a hand on their shoulder or their arm while they're going through this, having a physical presence. O is open communication. So being able to answer questions or talk about things. Having open communication. Again, our role would be to educate the patient about these things and then advocate for their decision. Normalization of grief reactions is N. So if they're feeling guilty, if they're feeling angry, or if they're denying this, if they're just feeling numb and they say, I just feel numb, I can't believe this, telling them that these are normal grief reactions is often important to patients. D is decision-making assistance, so helping them with making decisions. For example, do they want a funeral for the baby? Do they want the baby to be cremated? These might be things they've never thought of before. So educating them about the options, again, so that they can make decisions. Interdisciplinary involvement is I. Perhaps getting the chaplain involved, having the OB involved, or a neonatologist if this is a case where there was maybe a neonatal death. Perhaps the baby was born alive and then demised. Non-judgmental attitude is N. So caring for them, even if their grief response wouldn't be what yours would be, but caring for them in a non-judgmental way. Perhaps they have spiritual or cultural considerations that you don't have that would be different from yours. We still want to care for them in a non-judgmental way. G is genuine caring. You want to be genuine in your care for them. This kind of goes back to caring for them how you would want to be cared for given this circumstance. So again, this is the acronym RESPONDING, and it's helpful for considering how you would care for a grieving family. Sometimes you wonder, what should I say? We try to say the right thing, but we need to also watch, is what we're saying helpful? Things like, well, now you have an angel in heaven. What if they don't believe in heaven? What if they don't believe in angels? Is that helpful? And ultimately, some families don't want an angel in heaven. They want a baby here, so that might not be a helpful comment. Or this always happens for a reason. Something was probably wrong with it anyway. In many cases, that's not what they want to hear. They don't care if something was wrong. Again, they want that baby here. Or you're young, you can always have another child. They don't want another child. They want this child. So again, that's not helpful. That's minimizing what they're going through now. So thinking about our comments and what we should say is again, something else that's really important. It's okay to hear the patient and say, I know that you'll miss her. Or call the baby by name. This is very helpful. Or I'm sure that you've had many hopes and dreams for the future. Or I'm here to help you. I'm sorry this is happening to you. Those are all helpful responses. Let me know what I can do for you. Those kind of responses are very helpful. There are some special considerations when caring for the grieving family. You'll notice that there's a picture to the right. Purple background with a leaf with upturned edges, with a teardrop or a dewdrop coming down on them. This is produced by a company called Resolve Through Sharing, RTS, that does a lot of the bereavement kinds of pamphlets, memory boxes. There's also a picture here of a memory box. You'll notice that this picture, the purple background with the leaf, will be placed outside of a door of a family who's experiencing a loss. That way, if you walk in to answer a call light or something like that, you kind of know what you're walking into if they're holding a baby, what the circumstances are. So be aware if you see that sign that that's what that means outside the door. Also, you'll see here there's some pamphlets and things that we can give to patients and their families that can help them deal with a lot of common questions and concerns that bereaved families go through, helping other children cope with the loss, grandparents, loss from the father's perspective. A lot of different interesting things and needs are addressed within the pamphlets. Also, there's a memory box here. There's a picture of that to the lower right. This includes tangibles for the patient to look at, touch, feel. We can take photos of the demised baby with these objects, such as a little stuffed heart, the parents' wedding rings, things like that. The memory box, what would be included in there, is things that might be in the pictures, like the little stuffed heart, an outfit that the baby was wearing, pictures, a lock of hair, footprints, a measuring tape that we use to measure the baby, anything tangible for them. Also, look at where you're placing them as far as a room is concerned. Do we want them near the nursery where they can hear a baby crying? Or another part of the labor and delivery unit where they might be hearing babies crying? Probably not a good idea. Often you'll see these patients placed on a high-risk unit if there is one at the hospital, or placed further away from other patients. Also, it's important to acknowledge the loss. Come in and say, hi, my name's Melissa. I'm going to be your nurse. I'll be here until 7 o'clock tonight. I'm sorry about your loss. And you can tell them about what to expect. Continuity of care is very important. If we can use the minimum number of staff possible so that there is continuity. Oftentimes in these kinds of situations, unfortunately, patients can feel like we're gawking at them and that kind of thing. And once they do establish a trusting rapport, it's important that we keep them comfortable through this process. We don't want them to feel like they have to put up their brave front. Encourage questions. Certainly this is, an untraveled path for many people prior to this, so they probably have a lot of questions. You may notice also bereaved families asking the same question multiple times. It's hard to take all of this in. So we want to encourage them to ask questions. We want them to be comfortable asking questions. If desired, we want to allow them to have time with the infant. And there are a couple of different schools of thought. The majority of the time, though, you will see staff encouraging families to hold, touch, dress the infant. However, as your book notes, there are some studies that show that this can potentially be more harmful as far as post-traumatic kinds of episodes following this. Prior to this, if there were any tubes or wires attached in the case of a neonatal death, we want to remove those. We want to bathe and dress the baby. Involve the parents if they want to be involved. I mentioned taking pictures, also footprints, handprints, a lock of hair, anything that we can do to give them something to hold on to, something to remember, something tangible to touch. Those things are all very appreciated by families. This concludes the high-risk postpartum and grief and loss lecture. If you have any questions or concerns, please get in touch with me. Thank you.